different types of hernias and why they occur, discuss some treatment options, and also discuss what to expect from hernia surgery. And of course, at the very end, would love to answer any questions that you may have. So some disclosures. So there are going to be some graphic images and there's going to be some live surgery. So viewer discretion is advised. Otherwise, I have nothing else to disclose. So what is a hernia? So the exact meaning of the word hernia. So there's like in many things in medicine, where a lot of the words we use are derived from Greek and Latin. So in Greek, a hernia means a protrusion. In Latin, it means a rupture. But in a way, it's kind of a combination of both. And what I like to kind of tell most of my patients is that what a hernia is in its most basic form, it's an abnormal defect in a part of your body and a part of the tissues in your body, where parts of one area go into another area of the body where they're not supposed to be. And that's by far the simplest explanation. So our talk is going to focus on abdominal hernias. And so you can see there's plenty of different locations in our body where you can get these hernias, including in the groin, which are called inguinal hernias, or in the upper part of the abdomen. But there's also other hernias in our body. So for example, you can get a hernia at the diaphragm where the stomach or sometimes other organs can go through the diaphragm. They'll call these hiatal hernias, for example. You can also get a herniated disc in your spine where you see a bulge of basically compressing nerves and obviously causing significant amounts of pain. And of course, hopefully nobody gets this, but you can also even get a hernia in the brain. You can get a hernia where a part of the brain goes to a part where it's not supposed to be, and that can oftentimes be a very serious and very bad prognosis. But today's focus and our talk will be on ventral hernias and also inguinal hernias or hernias of the groin. So hernias really in the abdominal wall. And as you can see, our abdomens have a tremendous amount of tissue. They have muscle layers, they have blood vessels, nerves, and so they're very complex and important structures for our everyday function. So let's talk about inguinal hernias. So this is a very famous, the Vitruvian Man. This is a picture of Leonardo da Vinci, and he basically has a hernia, if you can see. So hernias is something that we've been dealing with for many, many years as human beings. So a few facts about hernias, especially inguinal hernias. So inguinal hernia repairs are one of the most common surgeries that you're going to see. They're performed in the United States. About 800,000 a year are performed. They are by far the more common abdominal hernia. The 75% of abdominal wall hernias occur in the groin. They're much more common in men than women, about 27% lifetime risk in men and 3% risk in women. And that's just because of the groin structures and the testicular structures in men that kind of predispose men to them. And about 20 million patients worldwide undergo groin hernia repairs every year. So why do we get these? And there's many different theories of why we as humans get them, why other animals really don't get these kind of hernias. And the big thought process is really because we started off in our development on all fours and then eventually kind of got on our feet. And because of gravity and the abdominal pressure that we face on an everyday basis, we've started developing these hernias. So what are the risk factors for getting an inguinal hernia? So certainly an increased age puts you at risk for them because our body, as we grow older, as we go through life, we go through normal wear and tear and changes, and our tissues lose some of their elasticity and strength, and that oftentimes will lead to the development of inguinal hernias. By far, men compared to women are more likely to get it, but there's also a congenital or genetic cause of this. Specifically in children, there is a reason why children get hernias is because there's the testicles. They start off in the abdomen and then they progress down into the scrotum. And sometimes in children, there's this something called the patented process vaginalis, that is basically this communication that allows the hernia to kind of stay open and persist. And that's why in children, you'll see these hernias, and they're usually not due to the normal wear and tear that we see in adults. Other things that can cause hernias, and so hernias in general, anything that increases the abdominal pressure inside the belly will increase your risk for hernias. So sometimes obesity, sometimes pregnancy, heavy lifting, significant straining. If you have a history of liver disease and you have a lot of fluid in your abdomen, sometimes that predisposes you to, gives you an increased risk for hernias. There are some people who believe that there's some studies, I should say, that believe that actually obesity for inguinal hernias can sometimes be protective, but for other hernias in the upper part of the abdomen, where obesity actually increases your risk for these hernias. Sometimes certain medical conditions, such as disorders of collagen formation, something called Ehlers-Danlos syndrome. There's also some other genetic causes, and also previous surgery. So a very common cause of inguinal hernias is someone who's had a previous hernia repair or someone who's had a previous incision, because the scar tissue that heals after any previous surgery is not as strong as our native tissues. So what are some of the symptoms that we have? So one of the common symptoms that we see, and I see in my office, is someone presenting to the office with a bulge or swelling in the groin area. It's usually palpable. Oftentimes when I ask a patient to cough, that increases the pressure in their abdomen, and that actually pushes their hernia out some more. And if I see that it goes through those kind of changes, or that I can even push it into the abdomen, I can pretty much diagnose a hernia from that. Sometimes it could be something as simple as pain in the groin area that can present it, can cause this presentation. But also, and kind of very rare, and I'll show you exactly why, but sometimes if, let's say, a piece of intestine goes into the hernia, sometimes people present with severe nausea or difficulty going to the bathroom, what we call obstructive symptoms. And those are sometimes seen. But then what's more interesting than anything is that about 30% of patients will not really have any symptoms, and many patients will not even know that they have a hernia. And so until they go to their doctor and actually undergo screening, they won't know for sure whether or not they truly have a hernia. And so this is kind of the anatomy, and we're not going to give a full-fledged anatomy lesson here, but if we can see the areas A, B, and C. So this is right around the area where in men, the testicles start off in the abdomen and kind of go through this little tunnel, which is called the inguinal canal, and then ultimately make their way into the scrotum. So around this area, there's a few common areas where you can get these little tiny holes or defects in the abdominal wall. And so if you look at the picture that's on screen left, you can see that sometimes it could be a piece of abdominal wall that goes into it. So basically the inner lining of the abdomen can sometimes go through this hole, or sometimes, and something that we absolutely want to try to avoid, is a piece of intestine or some other organ can follow along with it. And that's really the thing that we're kind of, really the most concerned about when it comes to these hernias. What we really want to try to prevent, something called incarceration and strangulation. And what that means is, if something goes inside that hernia and it gets stuck, or let's say it gets choked, that means that it's getting strangulated. So it could sometimes be a piece of abdominal fat or part of the abdominal wall, but we really want to prevent a piece of intestine from doing that, because if that happens, not only could it get it choked, it could also perforate, it can cause a severe surgical emergency. And so one of those things that when it comes to hernias, we really want to try to avoid this. So who should have a hernia repair or repair of an inguinal hernia? So patients who have any symptoms, so the symptoms that we talked about, pain, discomfort, nausea, vomiting, anything that really affects your overall quality of life, a persistently enlarging bulge that's getting worse and worse. Definitely someone who has an incarceration or strangulation, because that certainly could be an emergency. And other times patients really don't have those kind of severe symptoms, but they want to get surgery because they want to prevent the progression of those symptoms from getting worse. But when it comes to these inguinal hernias, there are certain patients and selected patients that we can actually also manage non-operatively. So, if we kind of the multiple research studies have been done, and one in particular really looked at multiple hospitals and multiple patients. And this classic study demonstrated that about 3% of patients will have an incarceration when it comes to these hernias. It's not something that you can predict. It's not something that you're going to know that's going to happen, but about 3% of patients who have these hernias are going to have them. And over time, hernias tend to, over the years and over certain periods of time, will start developing symptoms. And so for the most part, the majority of patients will require hernia repairs. But certain patients who really don't have any significant symptoms, who are not really progressing, or have really not really changing at all. Some of those patients, we could do what's called watchful waiting, where we can keep an eye on the hernia, and if there's any worsening symptoms, if there is any changes in patient's symptoms, then we can proceed with an elective repair, basically a planned repair. And there's also certain patients who may not have a symptomatic hernia, who have multiple medical problems. And in those patients, our goal is to try to correct those problems or improve them as much as we can before proceeding to surgery. So there are so one of the conservative options for treating these hernias in those selected patients is a hernia truss, or this hernia belt, that basically puts a little pressure on the area where the hernia comes out of and kind of keeps everything in place. It's a great tool for many patients. Again, it's not a long-term strategy, but for the short term, it's a great option. So what are some surgical options for inguinal hernias? So the way we used to do them, and thank God we don't do those anymore, is, in the olden days, we really didn't know how to deal with hernias. So people used to have their testicles removed, they used to have their bowels removed, and you can imagine in those days without anesthesia, it was not a very pleasant experience, and there was a very poor outcome for most patients. But then really in the late 1800s, and actually mid to late 1800s, we started producing repairs where we started using the body's natural tissues to close those defects and holes. And they were done through this incision right by the groin, exposing the groin structures and using the body's natural tissues to repair the hernias. And I'm, as you can see, a very big history buff. And you could see that all these people came up with various different repairs, and they had various different names for these repairs. And whenever we have something like that in surgery, it means that it's probably not as successful as it should be. And so, unfortunately, these tissue-based repairs had a very high recurrence rate. So they were done, and patients had to stay in hospitals for long periods of time. And then finally, the doctor on the right, who has the blue background, this is Dr. Lichtenstein. He basically came up with an idea in the late 70s and 80s that if you use the piece of mesh to support the wall of where that hole comes out of, where basically the hernias come out of, and put it together without any tension, you can prevent a significant amount of recurrences from hernias. And when he started doing that and his team started doing that, the amount of hernia recurrences decreased by a significant amount compared to any of these tissue repairs. And patients were having surgery on the same day. They weren't staying in the hospital for prolonged periods of time. They were getting back on their feet much faster. And so Dr. Lichtenstein really revolutionized the way we do these repairs with the open traditional repair. And this is a great picture of it. Basically, a piece of mesh being placed in the area where those holes happen, it's reinforced and basically stays there, and it supports the abdominal wall. So using this, we've progressed further. So since the 1990s, we've really been doing what's called minimally invasive surgery, where we've been making these tiny little keyhole incisions in the abdomen and placing laparoscopic instruments and these fiber optic cameras, and using monitors to do the same type of repair, not from the inside of the abdomen.
And so you can see this is the front abdomen that I showed you earlier. And now this is right, that same abdomen that we saw before. This is the back behind it. This is the from the inside of the abdomen. This is a view of the muscles of that wall, and you can see also the openings where these the structures that become the testicles eventually go in. And so, visualizing that with these fiber optic cameras, we can put a piece of mesh that supports this area the same way that we do it from the front, but because we make smaller incisions, it's usually less swelling, usually less pain, and usually a quicker return to function and quicker return back to your regular life. And we do these through these tiny little holes that we make in the abdomen, usually no more than 5 to 12 millimeters. And now, even progressing further, and something that I'm very interested in, and I'm seeing a significant increase in patients' use of, is robotic surgery. And so with robotic surgery, what we do is we make those same laparoscopic incisions, the same fiber optic incisions that we made before, but instead of the surgeon standing over you with these long instruments, you sit down at a console that has a 3-dimensional camera, and you use instruments that move around significantly easier and more versatile than the laparoscopic instruments. And you're allowed to do a much more careful dissection, a better visualization, and ultimately just means a much safer operation. And you can see it's the same ports as we used for the laparoscopic. They're about 8 millimeters or so. And with these 3 incisions, we fix hernias sometimes on both sides if we have to. And these are the instruments. See, they have these articulating arms that allow them to move around and kind of do much finer motions and a much better dissection. So let's talk about ventral hernias. So we talked about inguinal hernias of the groin. So ventral hernias are hernias of the abdominal wall above the groin region. They're usually acquired in adults, which means that they come over time, over years, with wear and tear on our body. Sometimes kids, for example, are born with hernias in their belly button. So those are not necessarily acquired. They're present at birth because of a failure of fusion of that area. The risk factors are very similar to groin hernias. Increased abdominal pressure can increase your risk for getting them. So obesity, pregnancy, heavy lifting, significant straining, the same disorders of collagen formation. Certainly, previous surgical incisions are much more important here, because so many surgeries are done through an incision down the center of the belly that there's an increased risk whenever you get these large open surgical incisions to get these hernias, about 20 to 30% chance of getting them, actually. They present very similar to inguinal hernias. They can come with a bulge. They can come with a palpable mass that can move in and out very easily. They can be associated with pain. Sometimes there's nausea and constipation for the same reason, with sometimes pieces of intestines or sometimes blockages happening. And just like inguinal hernias, they're just as high, they're also at risk for incarceration and strangulation, as we talked about before. And so this is really the area of the abdominal wall where you can get these hernias. And so you can see that, that your 6-pack muscles, or the rectus abdominis muscles, it's actually one long muscle on each side that has these little striations that look very nice on posters and things like that. But they're covered up with these tissues called fascia, which is your kind of girdle tissue of the abdomen. And so you can get hernias right around the center. You can get hernias right to the side of the muscles, and you can sometimes get hernias anywhere really where you get an incision. And this is kind of a cross section of the abdominal wall. And this is just showing you again, kind of that the muscles are all kind of wrapped around with this tissue, this gray fascia tissue. And there's these 2 rectus abdominis muscles in the front that kind of help keep you up, that stand you up. They're very involved in your breathing. And there's also these lateral muscles on the side that support give you the girdle function that you need to, to function every day. And so these hernias, they can be something very simple, very small, as a little tiny belly button hernia that can be, easily managed, or sometimes, and I'm going to give you a warning, that next page is going to be graphic.
Sometimes they can be pretty large. So sometimes they can be very complicated and very difficult to treat and require very complex surgeries to repair. So the treatment of ventral hernias, very similar to inguinal hernias. There's open traditional surgery, there's laparoscopic surgery, there's robotic surgery. And just like the hernias for the groin, we typically treat these with mesh usually. There are certain patients that we can watchfully wait, like inguinal hernias. But obviously, if there is significant symptoms and the quality of your life is being affected, that's usually something that requires surgery. For many patients, sometimes they may not be candidates initially, but we try to make sure they're ready for surgery. Sometimes if they're overweight, we help them lose weight. Sometimes if they're malnourished, we help them with nutrition. We treat their blood sugar and other medical disorders as well, to kind of make sure that we're operating in the safest conditions. One of the things that I always tell my patients is that I like to think of hernia repairs as repairing your roof in your home. You're not going to repair your roof on a day where it's raining or where it's snowing or there's a big storm around. You're going to want to repair it on a sunny day where you have your equipment, you have all your best tools, your best workers. So for our patients, we really try to get them to that sunny day, but sometimes, of course, we do have to repair hernias when they're incarcerated or there's an emergency situation. So this is going to be a video that I'm going to show you of a robotic repair that I performed, and I'm going to kind of explain what's going on. It's a very straightforward repair, and I'm going to kind of show you how really one of the benefits of these robotic repairs is what they allow us to do. So I'm going to start off here. So this is basically, you can see a little defect in the abdominal wall that now we're looking on one of the sides of the abdomen. This is a defect was just to the side of those rectus abdominis muscles. So this is a hernia that's kind of to the side of the abdomen. So one of the first things that I do with the robot is I create this space and surround the hernia. And you can see that right over there. So the hernia is over there on the bottom. So I'm kind of surrounding the hernia to create a space, number one, to put my mesh ultimately, but number two, so that I can ultimately reduce it. And so that's what I'm doing here. And you see the robot is cutting and sometimes burning in order to do this really fine dissection. So now I've kind of surrounded the hernia, and what I'm going to start doing in a second is I'm going to start reducing it, basically bringing it back into the abdomen. So bring that part of the abdominal wall that kind of went into the hole into the abdomen. And that's what I'm doing right now. Yep. And there it is. I'm kind of bringing the rest of that in. I'm kind of sweeping off the tissues that don't need to be on it. Okay. Very good. So there you can see the hole. So it's almost freed. And we're just taking off all the additional connections. We're sweeping everything. And in a second, you're going to see, yep. So now the hernia is pretty much almost everything that came into that hole is now reduced. I'm going to show you kind of all the stuff that really came out and was poking in. And so there's the hole. There's the area. And what we did was we expose the area a little bit more so that we can create a space that we can put a large piece of mesh to really reinforce the repair that we're going to do. So now in the next slide, which you're going to see, you're going to take a stitch. This is a barbed stitch that is absorbable, doesn't stay in your body. It'll eventually, within about 18 months, get completely absorbed. And we're closing the hole. And this is the benefit of the robot. This is something that's very difficult to do laparoscopically, but with a robot, this is very easy to do. And it allows us to do these very careful, complete repairs. So the hole is now completely closed.
We're just putting some last couple stitches to lock everything in. And now we put a piece of mesh. So this is a mesh that's going to be used to reinforce the area, cover the entire area. I'm going to suture it in or put some stitches to kind of attach it to the abdominal wall. These are also completely absorbable. Usually by 3 months, these are completely out of your body. And the mesh itself stays in the body. This is a permanent mesh that I'm using, and it'll eventually have tissue grow into it, and it'll become incorporated and part of the abdominal wall. And what I usually try to do if I can is I like to cover the mesh up with the body's natural tissues to prevent it from interacting with the intestines or any other structures. So we're just finishing up the stitches. We're just putting a few more stitches over here just to kind of hold everything in place. Okay, and now we're closing that inner lining of the abdominal wall that we took out and just covering the mesh up completely. And now that's it. So now we've closed the defect, and you can see what exactly we took out from that defect. So this all was inside that hole, and this was that hernia, and it's all completely out, and that area is covered and reinforced by mesh. All right, very good. But wait, hold on. Are we using mesh? Because there's all these commercials out there and all these ads. I mean, my patients get them all the time, including I get them on my phone all the time as well. And you're kind of wondering, is it a safe thing that we're using mesh? Well, so to answer that question is mesh has really been utilized in surgery since even as far back as the 1950s. And it's been proven very safe by the likes of Dr. Lichtenstein and his group, as well as so many other surgeons in multiple studies over the years since the 1980s. And because of this, it's really been the gold standard in our repair of groin hernias and hernias of the abdominal wall. And because of the use of mesh, we've really decreased the chances of recurrence of these hernias, and the complication rate is low. It's the method that is endorsed and preferred by the American College of Surgeons, by the American Hernia Society, the European Hernia Society, and pretty much most of the large surgical societies. And so if you compare the complication rate to patients after hernia repairs, there's really no difference in the complication rates amongst patients who have the mesh repair or the non-mesh repair. The only difference is without mesh, the recurrence rate is significantly higher. And really, one of the most important things that patients really should note is that the amount of pain after hernia repairs is not increased by the mesh. It's oftentimes due to other factors, sometimes inflammation, sometimes nerve-related injuries. Oftentimes, mesh is not the culprit. But what are the issues? So meshes have been used for many different reasons outside of groin hernia repairs. They've been used in bladder sling surgeries. And in the early days of these surgeries, there were some complications and erosions that have really since have been corrected. There are meshes that have been put on the market that have since been taken off the market, and they're no longer on it. The FDA regulates meshes significantly, and so does Valley Hospital. Anything that is even remotely questioned is immediately taken off the shelf, and I really haven't seen any of that going on. So mesh repairs and non-mesh repairs, as I mentioned, they have similar surgical risks of infection, injury, bleeding, wound complications. The only difference is that without mesh, your chances of recurrence are significantly higher. And so these are some pictures of some of the meshes that I utilized. And so this is, for example, for groin hernias, I like to use something made out of polypropylene, which is a plastic polymer that is easily bendable. I also like to use this mesh sometimes in abdominal wall hernias in the upper part of the abdomen. And this is a very safe mesh. It's a permanent mesh. It's really been the mesh that most surgeons have used over the years, and it is very safe and very effective. So the question now comes is,
what is the ideal repair for you? What's the ideal repair for every patient? So, the minimally invasive, the laparoscopic and robotic repairs, they've been shown to decrease pain in the early surgical period. They've been associated with a quicker return to function, and they're also involving smaller incisions, so typically less swelling, less bruising, but they're just as good as the open surgeries in the sense that down the line, they all have a same comparable outcome in that they all are equal in their chances of recurrence. So it's really the reason why we use this surgery is because of the initial benefits after surgery. There's been many different recent guidelines produced by the American College of Surgeons, by the American Hernia Society, that are really starting to favor the use of minimally invasive surgery. And for someone who's got two inguinal hernias, minimally invasive surgery really offers the benefit that you can take care of both hernias at the same time without making two big incisions. But there are some patients who are not appropriate candidates. Some patients who have had previous surgeries who have a lot of scar tissue in their abdomen and they're not exactly perfect candidates for minimally invasive surgery. There's also patients who have certain medical problems that contradict their ability to tolerate the surgery. So what's important is that when you talk to your surgeon, when you discuss the options, that you talk about the different options that are available and you decide which option is best suited for you along with your surgeon. So what do you expect after inguinal and ventral hernia repairs? So many of these procedures are typically same-day surgeries. We typically try to do these under general anesthesia. I always tell everyone that the first 2 days after any of these repairs, no matter whether we do them open, laparoscopic, or robotic, they're going to be painful. Pain is a very normal thing after surgery. We usually try to encourage people to avoid the opiate medications if we can, but sometimes we do have to prescribe them. With the robotic and the laparoscopic approaches, we're really seeing that less and less patients are using opiate medications when it comes to pain after these surgeries. And it really is, considering the epidemic that we have with the opiate crisis, it's a very good option. So after surgery, I always tell patients to always expect swelling, bruising. There's always some degree of constipation if after any abdominal surgery. Sometimes you may have weakness, you may not have your energy level, you may have poor appetite after surgery. And I always tell everyone after the surgery, because of the swelling and bruising that you get, ice is going to be your best friend. I recommend you putting ice on all the time after the initial surgery, which will improve your overall healing. So most people can return to some degree of physical activity, and I mean light cardio-based activity, typically within a couple of weeks after surgery. But usually the major restriction that we have after this is that for about 4 to 6 weeks, we tell patients to avoid any heavy lifting, so anything over 20 pounds. Another thing I always mention is that there's some degree of soreness, some degree of discomfort that may persist after the surgery. Usually not very severe, but some degree of soreness is common even for a few months after these repairs. Now, what are some of the risks involved with surgery? So one of the risks with any hernia repair, no matter how good of your surgeon is, no matter how good of a job he does or she, there's always the potential for recurrences. And I always quote that number as anywhere from 2 to 4%, depending on which hernias you're doing. Sometimes with the upper abdominal wall hernias, if they've had multiple incisions, sometimes that number goes up as well. Pain is very common after these surgeries. It's usually self-limiting in most people, but sometimes about 2 to 4% of our patients will have some degree of chronic pain after surgery. Any surgery has the risk of bleeding. Any surgery has the risk of infections. Anytime we make any incisions in the body, there's risks for complications related to wounds. Surgeons are human beings. Sometimes we can cause an injury. For groin hernia surgeries, typically we don't see significant sexual side effects, but sometimes you may have some degree of erectile dysfunction in men, as in the beginning stages, likely because of the pain and discomfort, but typically it's very self-limiting. And sometimes, very rarely, in a surgical emergency and a surgical injury, we may have to require additional procedures. And sometimes when hernias recur, it may mean an additional hernia repair in the future as well. So in conclusion, inguinal and ventral hernias are very common in the United States and can be a major source of pain and interfere with your everyday life and your quality of life. Modern surgical procedures are safer and they're associated with better outcomes. Mesh is safe and is the standard of care. And most importantly, if you have a hernia or if you have any questions or issues, always seek out a general surgeon, and they'll be very happy to answer your questions and make a diagnosis and ultimately set up a treatment plan if necessary. Thank you so much.
Thank you, Dr. Eliash. I love surgery. I love watching surgery, any live surgery. So fascinating how you repair that hernia. It's amazing. All right, we do have a question. Is anesthesia a local or regional or IV or inhale? How long does it last? That's one question.
Yeah, so to answer that, it really depends on the operation that you're going for. For any laparoscopic and robotic surgery, it has to be done under general anesthesia, which means that your body has to be completely relaxed for us to see everything and to also put the mesh in. So during these procedures, we inflate the abdomen with CO2 gas. So we have to really have everything relaxed. So that means given an IV medication to help you go to sleep, given a medication that helps paralyze your muscles, having a tube down your throat that's going to help you breathe during the operation, and the anesthesiologist also sometimes connects gas to that you can breathe in, that you breathe in during the operation until the operation's over. For some open surgeries, really, and you have to discuss this with your surgeon, depending on your medical history and your medical conditions. Usually these are done with some degree of sedation, or they can also be done under general. For us to do a repair under local, it's not really the best choice, because sometimes patients move, sometimes patients cough during an operation, and sometimes the hernia can come out that way. So we really want things to be somewhat relaxed during the operation.
Okay, second question regarding risks. Can you get blood clots?
Yes, so blood clots after any surgery, any surgical procedure, there's always a small risk for blood clots, because blood clots typically, they'll form for, there's this triad that we learn in medicine. It's injury, stasis, and missing the last one, but it basically, surgery has all those aspects. So you're making an incision in the human body, which starts your inflammatory process and the clotting cascade that we all have inside our body that helps us clot. In addition, during surgery, you're lying down, and sometimes after surgery, you're not really moving much because you're in pain or uncomfortable. So there is a risk of blood clots. One of the things that I do for my robotic surgeries, just because I'm operating in the pelvis where a lot of these blood clots form, I often give a small dose of a blood thinner right before the surgery in order to prevent that risk. For most other surgeries, for smaller surgeries, you typically don't need that, just because you can get patients on their feet faster. But it's one of the reasons why I tell patients not to travel by airplane for a few weeks after surgery, to really allow their body to heal and to decrease that risk.
Okay, great, thank you. Before surgery, should you stop taking supplements before, like fish oil or letter vitamins?
Yeah, so there are some medications and vitamins that we do ask patients to hold
For example, blood thinners, we do ask them to hold them, depending on which one. There's days to a week for some of them. For certain supplements, we're typically okay with it if anything does have an increased risk of bleeding. So garlic, for example, does have a slight increased risk of bleeding. We ask patients to hold that. Most other medications and also supplements I do allow patients to take.
Okay, how soon can you resume sexual relations after the surgery?
It's a very common question, actually. So I always tell patients that as long as you're not doing anything very rough or strenuous, and as long as your pain is not severe, as long as you can move around without any significant pain, you can resume sexual activity.
Okay, what is the mesh made of and how long does the surgery take?
Yeah, so meshes, there's many different mesh materials. There's many different companies that produce mesh. Some of them are made from the polypropylene material that I usually prefer to use, and it's probably one of the more common ones. There are some meshes that are made from polyester, some that are made from PTFE, some that are made from, there are actually some biological meshes that are made from pig skin and human skin. So there's a whole bunch of them. Some of them are permanent, some of them are resorbable meshes. Every surgeon has their preference. The majority of surgeons in the United States will typically use a polypropylene mesh. As far as how long the surgery is, so I always tell patients that the robotic laparoscopic procedure is roughly about an hour, hour and a half. The open surgery, somewhere about an hour or so.
Okay, and how long before you can drive and exercise?
Yeah. So any sort of heavy lifting and core abdominal exercises, such as sit-ups and planks, I usually tell patients to avoid for 6 weeks. As far as light cardio-based activity, like a light jog, a bike ride, and a pretty strenuous walk, typically about 2 weeks after surgery. As far as driving, my general rule is if you're taking the Percocet, absolutely no driving. If you're having a significant amount of pain, absolutely no driving. For most patients, it could be anywhere for about 4 to 5 days after surgery where they feel well enough where they can go for a drive without any significant pain.
Okay, someone is asking, is this method used to repair peristomal hernias?
So peristomal hernias are what they typically are. Is so if someone has a colostomy or basically a bag where they go to the bathroom from previous surgery, sometimes at those areas, so those are very prone to developments of hernias, and those are called peristomal hernias. So there are a number of ways of repairing them. The two methods that are probably the most common, one of them is called the sugar baker repair, and basically that uses a piece of mesh to cover and reinforce that area. There's also a keyhole repair, which is also same type of deal where they use a piece of mesh to reinforce the area around the stoma. It's really, as far as these hernias, they're very difficult to treat in the first place, so they still have a pretty good recurrence rate. But for peristomal hernias, those two methods really are the most successful.
Okay, we have a couple more, Doc. Hello, my mother can feel hers. When she does some activities in the house like laundry, she can push it in, she said. Do you think she needs surgery? She is in pain probably twice a week. She is 75, diabetic, and had 8 kids.
Yeah, well, so definitely she has the risk factors as far as having been pregnant beforehand. In addition, being a diabetic, your body doesn't heal as well as a regular, as a person who doesn't have diabetes. But I would say that really anyone who's having any symptoms or discomfort, any effect on the quality of life, at the very least should be evaluated by a surgeon. And even if you're not really having those symptoms, I think that every hernia really should be evaluated by a surgeon, and then in kind of in conjunction with the surgeon, you can kind of come up with a plan whether or not you're just going to follow it and follow up in the office, or you're going to actually do the repair, sooner than later. But I think having a surgeon who follows it closely is probably one of the most important things to have here.
Okay, someone is asking about statins. Should they stop taking statins a week before surgery?
I typically don't ask patients to take just to stop them. They don't affect the hernia repair in my case.
Okay, how do you determine whether a robot surgery or an open surgery is done?
So one, I look at a number of factors. When I interview my patients for these hernias, number one, I want to know what their goals are, what they do for a living, how often do they exercise, what are their goals with the hernia repair, because every hernia is different, every patient's very different. So number one, I get that history. I also get information about any previous surgeries that they've had, any medical problems that they have that would make the operation a much more of a difficult choice. Usually, if a patient is pretty healthy, doesn't have any major medical issues, no significant previous surgeries, my typical go ahead is a robotic repair, just because in my hands, I prefer it. It's a much better repair in my hands. I love the visualization. I love the ability to do the dissection with the robot. I love the ability to look at another side and look for additional hernias if there's some that are present. And so that's usually my go ahead. Some surgeons, they don't do robotic surgery. They may choose the open surgery. But that's why it's important to have kind of that discussion.
Okay, someone is asking, do I need to lose weight before surgery?
That's a great question. So for anybody who has a groin hernia surgery, typically we go by symptoms, and if the symptoms are pretty severe, we'll typically do the repair before anything else, before any other optimization. For hernias in the upper part of the abdomen, the ventral hernias, if a patient is not um, significantly at risk for the strangulation or incarceration, or the symptoms are very mild, I usually do try to have patients lose some weight, just because the success rate after surgery and the risk of recurrence is the success rate is higher and the risk of recurrences is lower. So every surgeon has a different kind of number for the BMI that they should go for, but I would prefer it to be somewhere, or when I say by BMI, I mean the body mass index. I would like to be as close to 35 or under 35 as possible, ideally, and that really does improve the outcomes after surgery.
Okay, we have one more question. If I have to fly after surgery, what can I do to avoid a blood clot?
Yeah, so I typically for my patients try to recommend not flying for a couple weeks after surgery, but so obviously emergencies happen. I will typically recommend, making sure you get up and walk around, make sure that you're moving around and your body's in motion. If you start developing pain or discomfort in your calves, or really any kind of signs of swelling in the extremities or in the lower extremities, definitely seek a medical consultation with somebody. But obviously, if you have to fly, that really would be the best solution. The other option is there's these compression stockings, and I oftentimes will recommend that patients wear them when they fly if they have to.
All right, well, that is it. Thank you so much for that very informative presentation. Thank you, everybody, this evening for attending. Please remember to